Hello, everyone. We're going to get started in a second here. I'll let everyone grab their seat. Double microphone situation going on here. All right, good morning, everyone, and welcome to Obesity Canada's Cost of Inaction in Treating Obesity briefing event. My name is Ian Patton. I'm the Director of Advocacy and Public Engagement for Obesity Canada, and I'm going to be your MC for today. Before we begin, I'd like to acknowledge that the land we are meeting on is the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples, and is now home to many diverse First Nations, Inuit, and Métis people. We also acknowledge that Toronto is covered by Treaty 13 with the Mississaugas of the Credit. Whether you're here in person or you're joining us virtually today, we appreciate you taking the time to learn more about the economic impacts of inaction in treating obesity in Canada and the need for urgent action. To start, it's my pleasure to introduce our speakers for today, who bring a wealth of knowledge and experience to this discussion. We have Lisa Schaefer, the Executive Director of Obesity Canada, Tim Dahl, the Executive Director of Global Data, and Dr. Sanjeev Soklingham, Scientific Director of Obesity Canada. As we all know, obesity is much more than just a single disease. It is a significant risk factor for more than 200 other chronic illnesses, which is why it's important that we have you all here today to share in our goal of improving the health and well-being of Canadians living with obesity. As someone with lived experience, I have felt the daily impacts of living with obesity, from pain and mobility limitations, low energy levels and mental health challenges, to social and environmental limitations, all of which impacted my productivity, my participation in society, and my family life. Before I received treatment, I was really unwell, and I was not able to do the things that I wanted to do or be the person that I wanted to be. The impact on physical health can be significant and compounding. As a leading factor in type 2 diabetes, high blood pressure, heart disease, liver disease, stroke, arthritis, cancer, and a number of other important health problems, obesity can have serious impacts for those living with it. This is why modeling the cost of inaction in treating obesity in Canada, which I was very proud to be a part of, is such an important new initiative. This data will help foster urgent discussions and strengthen our collective efforts to address the need for action to support those living with obesity in Canada. Today's session will provide valuable insights into the new data and our ongoing work, research, and advocacy efforts. But first, it is my privilege to introduce someone whose leadership is instrumental in driving Obesity Canada forward. Lisa Schaefer is the Executive Director of Obesity Canada and has only been at the helm of our organization for a couple months now, but she has been an absolute force in this space for many years. And if you've been around or familiar with Obesity Canada, she is a very familiar face. She has brought a wealth of experience and, most importantly, a great deal of passion to our organization and is tirelessly advocating for evidence-based approaches to obesity care and reducing weight bias across the country. Her commitment to empowering people living with obesity is central to everything we do. And under her leadership, Obesity Canada continues to be a leading force for change. Please join me in welcoming Lisa Schaefer.
Thank you. Good morning, everybody, and thank you so much for joining us so early on a Monday. I know it's a joy to start the week with us, though, I promise, and we're going to make the most of today. And this really is an important discussion, and I really appreciate the kind words that Ian just used to introduce me as well. I am very passionate about this conversation, and I'm so thrilled that so many of you were able to come out today. As Ian said, my name is Lisa Schaefer, and I am the new Executive Director at Obesity Canada, and I still get goosebumps every time I get to say that. I am thrilled to be here today representing our association for Canadians that are living with obesity, as well as the number of professionals, researchers, policymakers, and change makers that are truly engaged in these conversations. As an organization, Obesity Canada's mission is to improve the lives of people living with obesity. And our number one goal, truly, when you get to the heart of it, is to help reduce that social stigma that is attached to obesity and what it is to live in a bigger body. We want to change the way policymakers and healthcare professionals approach obesity because it has been so misunderstood for so long. And I truly believe that when we know better, we do better. So we know better, and now is our time to do better. Obesity is complex. It's confusing. It's not easy to describe, it's not easy to diagnose, and conversations about it can feel like knees and elbows. But that doesn't mean we shouldn't have them. Obesity is a chronic disease, very similar to hypertension, to diabetes, to many other chronic conditions. But Canadians living with obesity continue to face incredible amounts of barriers and really a lot of bias and stigma that comes at us at every touch point of our lives. Individuals living with this disease deserve better options for care and support. And that is why I am so thrilled that we have this new report and that you guys are in the room today to help us preview modeling the cost of inaction in treating obesity in Canada. This research truly serves to be as a collective wake-up call and a dire need for Canada-wide initiatives on obesity treatment and prevention. And a Canada-wide discussion about obesity is really where we need to start. Today, nearly 1 in 3 Canadians live with obesity. That means there is no one in this room or any of you who have decided to join online today that this disease has not impacted. You might not know that, you might not recognize that yet, but I guarantee you it is true. We've known this for some time as well. This is not new information. And even sadder, that number is intended to grow. We know it's on an upward trajectory. We also know that the Canadian Medical Association and the World Health Organization recognize obesity as a chronic disease. But today, in the year 2024, no province or territory in Canada officially recognizes this as a chronic disease. How can that be? That makes no sense. We need to make it make sense. The reason that this is a really big problem truly is because of stigma. It's about bias. It's about weight-based bias and discrimination. And it's about the inaction that people take because we don't understand or don't want to see people living in bigger bodies as worthy as care and treatment. We're not willing to see obesity as the chronic disease that it truly is. As a society, we have to stop perpetuating the myth that obesity is about a big person with an unhealthy love of food or truly an unwillingness to exercise. We need to see obesity through a lens that goes beyond BMI and diet culture. And we need to dismantle the widespread misinformation that accompanies that mindset. If you just try harder, I'm pretty sure you can do this on your own. I'm pretty sure if you pay me more, I could probably help you get there too. We've heard this, we've all been steeped in this. No one is immune to what we've been told for so long. We need to demand better from our government, from our systems, and quite frankly, from our fellow Canadians. We need to start treating this as a chronic disease, and we need to start treating people living in bigger bodies with more care. Shortly, I'll hand over to Tim Dahl from Global Data and Obesity Canada's Scientific Director, Dr. Sanjeev Saklian, and they'll take you through the report's finding. As you listen, I really ask you to pay attention to one important theme throughout this entire report. Our failure to recognize obesity as a chronic, progressive disease has had substantial economic impacts on Canada. This report also shows that there are profound implications for Canada that go beyond the individual. Canadian policymakers, private insurers, and healthcare professionals need to understand the financial burden, the cost of inaction, how much we're spending by not doing better, even though we know better. Access to care and prevention strategies are the cornerstones of health public policy, and this particular chronic disease should be viewed no differently than any other. If we invest in interventions far earlier in the disease process, we can disrupt disease progression. We know this to be true. Obesity is an upstream disease. If we take care of obesity, we can actually take care of the possibility of several other chronic conditions. But we don't see that as the case. We're happy to fund and support care and treatment for these downstream diseases, but we still are being pejorative at the top and really putting the burden on the patient at the top because we aren't recognizing that that actually is a chronic disease that this person is living with, and a chronic disease that has really conditioned them to live their lives a certain way. We don't ask for help. We don't see ourselves as humans, as whole people. How could we? We're faceless blobs on every newscast that you see. Today's report findings reinforce that when, and please note when I say when and not if here in this moment, when we change our mindset, we lay the right foundation and invest in the type of health interventions and treatments given to any other chronic disease. And when we do that, we'll also get back to being the version of Canada that we can be proud of. By addressing obesity first, we can mitigate so many other challenges for people. Urgent action is truly needed. Investing in effective obesity treatment and prevention strategies is not only the right thing to do for Canadians living with this disease, but it is crucial for our economic well-being as a nation. There's a lot we don't know, but this report gives us a benchmark. We have the information and we have the tools. Now we need to have the conversation to understand how we get patients what they need and ensure that our systems and our communities are there to support them. We need a collective push to change our fundamental understanding of this disease as a nation. There's still a lot to be done, and we know that we can't do it alone. We also know that obesity goes way beyond this one disease. That's why it's so important and why I'm so excited to see the faces that I see in the room here today, because we have to come together to start this conversation. Action and strategies are truly what we need. So again, as the gentlemen take you through this, more of the report findings, think about how we can all come together and be a collective. Consider that this is a discussion not just about this report, but how we can start sharing ideas, how we can truly start working together to impact change. The sum of us will be the better than the one of us. We need a collective push. So before I hand it over to Tim and Dr. Socklingham, I'd like to acknowledge that Eli Lilly and Lilly Canada's funding this report is monumental for us. You are giving us some armor that we can use going forward to really push this conversation and demand better care and access for everyone. We cannot thank you enough. I really appreciate everyone coming out today. Thank you for taking the time to attend and to learn. I know that we can do this together. We're here and we hope that we can count on you as allies, as advocates, because now you can all add that to your business cards as well. Every single person in this room should be an advocate for obesity. When you see something, say something. When you can help, help. We all have power in whatever space that we take up in this world, and I invite you to use it for the good and to help us push this conversation forward. Because we can really make a difference in what it is to live with obesity in Canada, and we can make the reality of being a person who lives with obesity in Canada a lot better. So thank you. And with that, I'll pass it over to Tim to come up and share more of the details and data findings.
So I was told we're having some audio issues. Are we good to go? Okay, I was going to tell you a time travel joke, but nobody laughed. Some of you got it. So I'm going to talk about the cost of inaction in treating obesity. And when we think about obesity, this truly is the best of times and the worst of times. Worst of times because obesity prevalence is at an all-time high. Here in Canada, about 1 in 3 adults, 30%, are dealing with obesity. But it's also a really exciting time. You've heard some passionate people, and Ian and Lisa and others, who are advocating for improved access to care. And we've got numerous life sciences companies who are investing heavily in new treatments. So it is an exciting time. What I'm going to do is first walk you through just a general overview of the way that we calculated these cost estimates. We have a paper that's currently under review with the journal. It's in that kind of revise and resubmit stage. So we're hoping that we'll have more detail on the data and methods available soon. But in the meantime, on Obesity Canada's website, there's an executive summary of the findings. So we start off with the prevalence of obesity, again, about 30% of adults in Canada. And we looked at the direct and indirect costs associated with that. The direct costs would be things like, because of the health conditions associated with your obesity, you have more doctor visits and more hospitalizations. And what is the direct economic cost of that? Also, people are more likely to be admitted to a nursing home, and we calculate those costs. But interestingly, the bulk of the cost is really on the indirect side, that people with obesity, they're more likely to not be in the workforce, whether it's because of their health or discrimination. We don't really understand the reasons why they're not in the workforce, but they're less likely to be in the workforce. For those that are in the workforce, because of their health conditions, they miss more days of work. They report more days where they go to work, but their productivity is lower because of their health. We call that presenteeism. We have other conditions such as just disabilities and the implications for pension programs and disability costs, and then premature mortality. Unfortunately, there are many thousands of people that are not with us today because they died prematurely due to their obesity-related complication. We look at these from the perspective of individuals and households, from the perspective of employers, from the perspective of government. So when people are missing time off from work, or their productivity is lower, or they're unavailable in the workforce, this has implications for our economy. It has implications for profitability, for economic growth and output in general. And of course, when we look at this from the government perspective, not only are there higher medical costs and costs for long-term care, there's lower economic activity, which means lower income tax revenues and sales tax revenues and higher pension costs. So here's the big number right here. $27.6 billion is our estimate of the economic cost. And what you'll notice is that about 3/4 of these costs are related to the indirect economic costs of obesity, about 1/4 associated with the direct medical costs. These estimates are about 20% higher than previously published estimates, but it's in line with those estimates. If you take into account that those estimates are a number of years old and you adjust them for inflation, you adjust them for the growth and prevalence of obesity, those numbers are pretty close to what our numbers are. And another recently published study also has their own estimate of the economic burden of obesity, and although they used a little bit different method and some different assumptions, their numbers are very close to our numbers. So where does the higher direct medical costs come from? Well, we took a look at the Canadian Community Health Survey. This is a major source of our data, and we use that data and supplement with some other sources where we needed some information. But this is all self-reported data, and because it's self-reported, sometimes there's a little bit of a bias in the self-report, and the bias probably is towards conservative. That is, when a person reports their height and weight, they tend to over-report their height and under-report their weight, and so their body mass index and the prevalence of obesity actually might be higher than what is in the self-reported data. So when we present these numbers, just note that if there is a bias, it's probably towards being conservative. And on top of that, when we looked at different assumptions, we tended to take more conservative assumptions. But in the data, the estimates are that people with obesity have about 1.7 additional visits per year to their general practitioner, more specialist visits, slightly more emergency visits, more hospital stays, more home health visits, and more prescription medications. And this adds up. It's about $572 per year more for a person with obesity compared to a similar person with healthy weight. Similar meaning of a particular similar demographic controlling for their age and their gender. We also look at long-term care costs. And when we look at long-term care costs, we look at the additional people that are in long-term care that we can attribute it to their obesity-related conditions. And we look at the extra cost of being in long-term care compared to living in the community. So we're not taking into account, for example, that if you're in the community, you still have to eat and have shelter and things like that. And so this is the additional cost. But as mentioned, about 3/4 of the costs are in the indirect part, and many of these have implications for the workforce. So higher absenteeism, about $682 million per year. And what we notice in the data is that people with obesity report more missed work days. And most of this comes from their chronic conditions, but there also is an increased risk of injury associated with obesity. One of the higher costs is presenteeism. So in the Canadian Community Health Survey, when they're asked a question about how many days per year do you have reduced productivity, and that's about $6.8 billion in reduced productivity. So that is one of it's the second largest component of our cost study. The largest component, actually at $8.2 billion, is reduced workforce participation. When you look at the data and you look at are they in the workforce and you control for their characteristics, we find that women in particular are much less likely to be in the workforce if they have obesity compared to women with healthy weight. Men are slightly less likely to be in the workforce if they have obesity compared to men with healthy weight. And I've got a slide later that will show those kind of gender differences, but that is a major component. That's about 130,300 fewer people in the workforce than what would be expected in the absence of obesity. Now, some of those individuals, about 43,000 of those, also are eligible for pensions because of their disability. And so those 43,000 are part of that 130,000, but there's additional costs associated with those pension payments. And then we have lost wages and economic activity due to premature deaths. What we did was we looked at the cause of death. Now, people on their death records, it doesn't say they died because of their obesity. They died because of their heart disease or their diabetes or other condition. And so we use what's called an attributable fraction, where researchers have shown that if you have, for example, diabetes, what proportion of those cases can be attributed to your obesity? And we could use that to calculate not just the number of premature deaths, but also the demographic distribution of these individuals. And then we took, how many of these individuals likely would have been in the workforce based on labor force participation rates of men and women of different ages, and what's their average wage that we would have expected, and we calculated about $2 billion in lost economic activity due to people that have died prematurely. This number is actually quite conservative because when the government does analyses and they value a death, they use a societal perspective, and I don't remember exactly what the number is. It's maybe $10 million, somewhere in that range, per death. If we would have used that government number, then our overall economic burden would have been 3 or 4 times higher. So this is a very conservative estimate, looking at it in terms of lost wages and not necessarily a societal perspective. So when you take these different components of lost productivity, it equates to about $7.5 billion per year. When we look at this personal income loss, this is from women not in the workforce, about $3.8 billion. And when we look at lost wages for other reasons, it's about $10.2 billion, with a portion of that being, the large portion being people not in the workforce, and a portion of this being people that have died prematurely. We then looked at what are the implications for sales tax revenues for Canada, for income tax revenues, and we did the calculation. So about $1.2 billion lower income tax revenues, about $807 million from lower earnings, about $3.2 billion in sales and corporate tax revenues lost. And so those numbers start to add up, in addition to, of course, the higher cost of care. Also higher disability payments. One of the interesting things here is that obesity affects men and women differently. Even though they have similar prevalence of obesity, we found that in the survey for women, we saw more absenteeism and more presenteeism associated with obesity than we saw for men. We saw lower workforce participation patterns for women than we saw for men. For example, obesity reduces the labor force participation rate for women by 5.3%. Again, women with obesity compared to women with healthy weight. For men, it's a 0.3%. Also, we found that for women with obesity, their earnings were about 4% lower than women with healthy weight, but we saw no effect for men. This number is actually probably on the conservative side. When we look at data from other countries, the reduction in earnings is usually kind of in the 5 to 8% range, but because of the way the data is collected in category form, it kind of biases the numbers towards 0. So that's probably on the conservative side. So this is the take-home number there is, if I can go back one slide here, 21.7 billion in lost economic activity, and again, that's probably on the conservative side. Thank you.
All right, so Tim left you with some numbers here to think about in terms of impact, and I'm here to now delve into a little bit of what does this mean to us as we're all here as part of this collective to really focus on the impact of obesity and the impact of inaction on obesity care. So I wanted to start off, as Ian mentioned, I'm Dr. Sandy Sokoling, I'm Scientific Director of Obesity Canada. And similar to Ian and Lisa, I just want to thank all of you for being here this morning, both in the room and virtually. It communicates to us your shared passion and commitment to really addressing the disparities in care and the impacts of obesity for people living with obesity across Canada. So another number I'm going to keep reminding people is 1 in 3 throughout this presentation. So as Lisa said, Canadians living with obesity face widespread bias and weight-based discrimination. And I think that underpins what Tim has been talking about in his presentation. And what we saw in those numbers and in the stories many of you hear on a day-to-day, whether it's your personal lives or professionally, is the consequence of inaction. It is why we need a collective action, and I would argue a movement to address stigma and bias. Over half of adults who live with obesity report facing weight-based stigma from coworkers, which can contribute to mental health impacts and impacts on well-being, which then further perpetuate this vicious cycle. And again, you see it in the numbers that Tim highlighted. As a healthcare provider who's dedicated most of his career to addressing the impacts of obesity and supporting the mental health and well-being of the patients I see, it really pains me to see reports where up to 2/3 of healthcare providers or 2/3 of patients living with obesity who come to healthcare providers are experiencing weight bias from a healthcare professional. And you can imagine, or maybe you can't, how that impact might be for an individual living with obesity to have that on a repeated basis. These are often not one-off occurrences. So again, thinking about the economic impacts, I would like to also think about the systemic and healthcare impacts that people living with obesity face that further perpetuate some of the challenges and health equity issues. And these biases are deep and continue reinforced in many ways. And Lisa mentioned there's a lack of consensus in Canada in recognizing obesity as a chronic and progressive disease. And that's despite local and international organizations, including Obesity Canada, advocating, acknowledging, and other medical associations identifying obesity as a chronic medical condition. However, federal and provincial governments continue to lag behind. I'll just say anecdotally, this is not in my notes or in my presentation, but anecdotally, there was a report in Ontario a couple of weeks ago on the burden of illness in Ontario that showed an exponential increase in chronic conditions in the next 20 years. And of course, obesity was identified as a major factor driving the burden of illness in this province. However, it was identified as a risk factor and not as one of those chronic medical conditions, which further perpetuates what we're talking about in terms of the impact and of inaction and the stigma that people living with obesity face. And so bias and stigma are pervasive systemic effects with negative impacts on resource allocation, research funding, and comprehensive care and support to implement strategies to address, treat, and prevent obesity. That leaves over 8.7 million Canadians with limited options, if any, for receiving the right care at the right time. We can't ignore these statistics, but more importantly, the stories we hear in healthcare and our own personal lives where people living with obesity are left behind. Access to evidence-based treatments and preventions remain limited, and the numbers that Tim just shared will just continue to grow exponentially. People living with obesity who have limited access to effective treatments for obesity will continue to face significant financial barriers. You saw that in some of those indirect costs due to impairments in work, functioning, and disability. And there's also an increased likelihood of complications and risks with over 200 comorbidities that have been associated with obesity, including diabetes and heart disease, which the report shows, which is taking its toll on the healthcare system and the Canadian economy in profound ways. And even for those who may have access to private insurance, less than 20% of Canadians with drug benefit plans have access to medications approved by Health Canada for obesity treatment. And for the other pillars of treatment for obesity, including metabolic and bariatric surgery, which is covered in many provinces, but unfortunately, patients referred to surgery can wait up to 8 years before meeting a specialist or receiving surgical care. So imagine that, 8 years in some provinces. The modeling the cost of inaction in treating obesity in Canada findings emphasize the urgent need for effective Canada-wide public health strategies to treat and prevent obesity. Today, we do not have adequate team-based supports that are essential to delivering evidence-based obesity management. We know what to do. Our obesity treatment guidelines in Canada have been adopted in many places, disseminated nationally, yet the availability of evidence-based treatments, including intensive behavioral interventions, surgical interventions, and pharmacological interventions, remain limited. Investing in effective obesity treatment and prevention strategies is not only the right thing to do for Canadians living with obesity treatment, but even more, it is the most critical thing to do for our economic well-being of our country. There is a lot to be done, and everyone has an important role to play. Policymakers and employers should consider how to increase access to care for Canadians living with obesity and medical professionals who need to ensure patients receive evidence-based treatment, and patient-centered care also need the tools and access and policy changes to support that. But to make this happen, we need our government to acknowledge obesity for what it is, a progressive and complex chronic disease that more often than not requires medical support. And this is where we look to you, our partners, to help continue the conversations and emphasize the need for urgent action. By working together, we can create a healthier future for all Canadians affected by obesity. In order to get there, we need to reshape the narrative and correct the misconceptions of obesity, and we need it now. I'm looking forward to the continued conversation with Lisa, Tim, and Ian as we explore what this looks like, and to take questions from people here in person and who are watching online, as we need to continue this dialogue for this collective movement. So thank you.
All right. Is my mic's working now? Okay. Thanks for that, Dr. Socklington. So I'm going to ask Lisa and Tim to join us all up here, and we'll take some questions. For those of you that are in the room, please make sure you raise your hand, and we'll get you a mic so that the people that are joining us virtually can hear you. So if you're going to ask a question, make sure you wait for a mic. If you happen to be joining us virtually, you can use the chat feature to ask questions, and we'll get those through as well. But to get us started for right now, I'll start with you, Lisa. So you talked a little bit about weight bias and stigma and discrimination that fuels inaction in your talk. What are some of the biggest misconceptions about obesity, and what do you think we need to do to help shift that mindset?
Good question to start with. I think a lot of the misconceptions around obesity have to do with the diet culture and that narrative that we've all been steeped in for so many years. And that includes our healthcare professionals as well. So with that diet culture narrative, we've really taken on this belief that it is the individual's fault, and or it's also a moral failing if you live in a bigger body or you're living with obesity. But it also isn't that simple either. But weight bias and stigma itself definitely, is compounded in our world by all of the things that we hear all around us all the time about eat less, move more. And trust me, if it was that simple, we wouldn't still be having this conversation. As someone who spent way too many days, years, hours, months on a treadmill trying to get someplace that I was never going to be able to get because I was trying to treat a chronic condition with diet and exercise. And that isn't how you treat a chronic disease. Diet and exercise is fantastic. It should be a part of everybody's life. It should be part of living healthy. And we should be focused more on well-being overall and not just changing the size or shape of one's body. Because someone with in a larger body may not have obesity, and someone in a smaller body might have obesity. It truly is not what we think it is or what we've been told for so long. So it's complicated and it's complex and it's confusing. And I think one of the best things we can do is invite that curiosity and confusion a little bit. Because when we're curious, what we aren't being is stuck. We aren't sure of a thing. And I think that's a big part of our challenge, is that people are so sure of something right now that they understand this and they got this. All you got to do is move a little more, eat a little less, maybe give me a little more money, then we'll get you there. And that truly is not what this is. So I think there's a lot to this. It's a big tangled ball of lights, and we got to start somewhere and start helping people pull it apart. Because again, having my own personal lived experience, when you live with that belief, you're really cloaked in 5 layers of shame. And you go to a gym and you think you're doing good for yourself, but everything around you is about how not to be the person that you exactly are. And that's because of your body. And I always knew that I needed to make a fantastic second impression, as my friend Brendan told me, because my body was going to make my first impression for me. That's really sad. And I think one of the best things we can do is truly help everyone see this as a chronic disease and not a moral failing, or that somebody is fat and lazy, or that they don't understand how to just get healthy. Because I understood a lot. I became a very high-functioning person. I understood a lot in life, and one of the things that killed me the most was that I couldn't figure this one part out. And I couldn't because it's complicated, because I needed multidisciplinary care, and because I also, quite frankly, needed a society that was being a bit kinder to me and made space for me as I was, because I was pretty awesome already. But I didn't know that. It took me a long time to get there. And when I truly understood that I was living with a disease and not a failing, a lot of weight got lifted from me, and I was able to show up for myself differently. And I think if we could all start showing up for ourselves and each other differently, we could help make this change that really would solve so many challenges. We know this is such an upstream disease that if we took it seriously and understood, I'm willing to fund and support care at all these other diseases, but I still, for some reason, believe it starts because somebody did something wrong up here. It's not the case. This started long before I was a glimmer in my mother's eye. It's all about heredity, it's genetics, it's our environment, it's so many things. And it also is really important for me, as part of my messaging, to let everybody know that body diversity is also a really good thing. We should all look different, and that's okay. And bodies are going to change over time. And also body autonomy is really important. There are a lot of noise and conversation right now about disease treatments. If you don't want to change your body, that's fine. Be healthy, be happy, and show up as an awesome Canadian. That's the best thing we can do for each other. Did that answer the question?
So now you all know what I mean when I said she's a force. Thanks for that. Actually, I really like the comment you made about curiosity and how we've been so set in our ways for so long. And with my background coming from kinesiology, and I was an exercise physiologist and those sorts of things, like while I was living with obesity, I was also that person who believed that this was real simple. If we get everyone active and we start eating healthier, I contributed to that as someone living with this disease. And so like I really appreciate the idea of being curious and being open to learning more, because we have learned a lot about this disease in the last little while, the science of it and how to manage it and those sorts of things. So great comment. Tim, I'll move on to you now. As someone who works with data regularly, was there anything unexpected in the findings or anything that surprised you?
Well, I guess one observation with data is there's never enough. Sometimes you want to be able to look at certain trends, either over time or across characteristics of people, and there just seems to be a lot of gaps in the data. Having said that, the findings for Canada are very similar to what we've seen in other countries. It's just, a little bit more healthcare use associated with obesity, a little bit more absenteeism, a little bit more presenteeism, a little bit less workforce participation, and it just all starts to add up. So I guess nothing surprising in the data, unfortunately, because that burden is there. And if we don't treat that burden is just going to continue year after year after year. So sometimes people say, but it's so expensive to treat obesity. And the counter argument, it's too expensive not to treat obesity.
Yes. Excellent point. And again, as someone who's lived with this, and I've experienced that lack of productivity and stuff when I was at my sickest, it's something that hit home. Like I could be more involved in the world that I'm living in if I could manage this appropriately. Sanjeev, on to you. How might the results shape the future decision-making or strategies?
So I think it's nice to have data and numbers to back what we hear from people living with obesity on a day-to-day. And so I think we've used the term collective a lot in different ways throughout the presentations today, and that's deliberately because I do think this requires multiple layers of efforts to really address this. So one is we now have data on the economic impacts, both direct and indirect. And this is, again, a fuel for our fire for advocacy in terms of thinking about how do we make changes from a policy level, both at a federal level and provincially. And what does that start with? That starts with changing the language on reports, websites, et cetera, that state that obesity is a risk factor or not, sometimes leaving out obesity in some of the dialogue here. And so really identifying that obesity is a chronic medical condition. So that's first off. Second is, with these economic numbers, with the number of Canadians impacted and the total burden. So if we go beyond numbers in terms of dollar values, but the numbers in terms of people who are living with disabilities, who are impacted in terms of their day-to-day quality of life and their overall health, I think this is how we need to bring together different arms and stakeholders across federally, provincially, to think about what is our strategy and approach to address obesity in a more comprehensive way. And so if you look at what we have right now, we have guidelines and evidence about effective treatments and we need continued funding and research to continue to improve those. We also think about how do we implement those in our provinces and communities on a day-to-day basis. And so that requires a focus on how do we bring this interprofessional team-based model of care to Canadians living with obesity and have the resources to do so that it's accessible, not to those who may be able to pay out of pocket, which are the very few when you look at the disparities of care and the health inequities for people living with obesity. So I would say it starts with bringing together groups like this, like people here, with government, and having people with lived experience really sharing their stories and continuing to advocate, because now is the time we need to make change.
Yeah, another excellent point. And in the work that we've done advocating and like when we talk to policymakers, the conversation has always been like they're open to having the conversation about obesity, and when you have the lived experience kind of paired with the medical or clinical side of things, those conversations can be very fruitful and open. But I find it always comes back to the economic discussion with people like that, and they're always worried about the cost of actually doing something about it. And I think what we've got now is a tool that says, the cost of not doing something is going to be more, and we're already spending that money. So let's be innovative in how we're approaching healthcare in Canada, and let's start, thinking proactively rather than reactively when it comes to obesity, and start treating it early. Awesome. So I think what we'll do now is we'll open it up to the audience. So if we got some questions.
My name is Michael Battelle from the Fatty Liver Alliance. And first of all, congratulations, Obesity Canada, for this really excellent work in quantifying inaction, and for Lily for supporting this as well. I wanted to ask the panel and follow up with a comment that Lisa said about the importance of upstream work. You didn't mention things like tools, for example, continuous glucose monitors that might help patients to be able to see the impact of insulin resistance, as an example, in glucose, and behavioral support. So I thought maybe you could talk about those two just a bit.
Do you want to talk about the pillars for a second?
Sure. I mean, I can speak to that, Michael. But I think we need to continue to arm our healthcare workforce with the tools to be able to manage obesity. So you mentioned monitoring and measurement. I think there's some ways in which we need to first unlearn what people have learned over decades, which is reducing obesity to eat less, move more, and we need to move to actual evidence-based treatments. I think there's the assessment phase, which you're talking about, and how do we have conversations with individuals living with obesity and the assessment of obesity. And remember, our definition is more than just a BMI. It is about the impact on health and the functioning of individuals living with obesity. And so I think that's an important piece as well. I think we also need to think about how do we bring together that behavioral intervention and supports, which are so integral to all the treatments. It's one of the key pillars in our treatments. And as you know, most of that is offered through private or pay-out-of-pocket type of services. And so this requires ways in which we can build around existing infrastructure for care and having accessible supports. And that could be through investment of kind of team-based models, testing those team-based models, implementing it, but also linking people to existing resources and maybe bolstering up parts of our healthcare system where we might be able to upskill certain healthcare providers to provide some of those skills in our existing teams as well. Yeah.
I mean, if there's a way to prevent disease before it starts, especially in youth,
Yeah.
that would be a good approach as well.
Yeah, 100%. So prevention is absolutely one of those things, and I know that there are national efforts to look at, in different pockets, innovative ways in which to do that with children and youth, as we know, because, again, if we can do some prevention work and at least awareness, it can also engage people into early intervention, if not prevention as well. Yeah. Yeah.
And we know from when you're speaking of tools as well, it really is all about the conversations. And it may sound simple, and I know I love you for loving stats, because, man, we need people like you in this world, because you help qualify kind of my lived experience and kind of these numbers. And when we think about it, when we talk about prevention, one of the best things I think we can do from a prevention point of view is to treat the adults. A lot of what we learn is in our homes, and what we see is in our homes. And if I could have seen my parents being taken care of and getting treatment for their diseases, who knows what that could have meant for me. So that's a lens that I have on prevention as well. One of the best things we can do is take care of the grown-ups in the room, and then look at what we would also get from an economic point of view and how much good would come back into the workforce, how much we could relieve some of that tension and stress in our economic model as a country, let alone the healthcare system. I truly do believe that if we treat obesity, we will be able to bend the curve in healthcare and really take care of a lot of different things. But again, let's start by providing the right care and treatment, and nobody can do that until we can start having these conversations. And so I really do look to our clinical practice guidelines that Obesity Canada released in 2020 that really do support, and they've been implemented and are seen as the gold standard around the world. And quite honestly, they're being implemented in other countries better than they are in Canada today. So we've kind of got the answer key, or we've got the lid to the puzzle box, but we're still kind of bumping around. And that's a big part of what we need when we say we need to talk to our policymakers and find more of those amazing change agents that are out there with us, because it really isn't a huge shift. There's a lot of hope within this conversation, and I want to make sure that comes through as well. Your numbers, again, are amazing, but let's focus on the hope as well, because we need that too. If we can show people that there are options, there are treatments, that it isn't just you. come towards us, we can all start having this larger narrative. And a wise man reminded me the other week that sunshine is the best sanitizer. So by shedding light on these things and actually having the conversations and making sure that there's space for these kinds of conversations, that actually will do a lot unto itself. A lot of people will feel seen. A lot of people will be heard. Because this really is bigger than obesity. This is a chronic disease, but we really need to heal a lot of parts of the world that we live in every day.
Yeah, and just to kind of build on that point about prevention, for a long time in this space, prevention meant we ignored treatment, and it was, prevention was just we need to get people active and eating healthier. And that's a lot of the conversation. And so someone who comes from that field, and I honestly believe that being active is one of the best things you can do for your health. And, nutrition is incredibly important and something that needs to be part of anyone's chronic disease management. So I'm not saying prevention isn't important. It is very important, but they need to happen together. Prevention and treatment can't do one successfully without the other, I think is how we need to kind of frame this now. And when we talk about prevention, we need to look at prevention in a real broad kind of view of it, because prevention is more than just getting kids active and teaching nutrition or healthy nutrition and stuff. There's environmental stuff and societal stuff. It's a big systemic thing that we need to approach. And none of those individual interventions or prevention approaches is going to be successful in and of itself. So we need to look at it as a collective, which is really important.
If I could just add to the discussion here. So you mentioned just having a toolkit, and I think one thing we know about obesity is that every person is unique and they need a unique solution. And so when that person sits down with their provider and looks at the different options, they kind of need that full toolkit of what's available to them. We use body mass index as a kind of a measure of obesity. We know it's imperfect, but it's one of the few measures that we have, right? If you look at the BMI distribution, you'll see there's a whole bunch of people. It's a very skewed distribution, and there's a lot of people sitting there with a BMI of 30, 31, 32. And about a quarter of the people with obesity, they just need to lose 5% less or body weight to exit obesity. And that is very achievable for many people on the treadmill. Not everybody, but for many people, it's just nudging them to exit obesity, reduce their risk for these chronic conditions. Then we have about another 25 people who have a BMI between about 33 and 36. They need about 10% or less body weight to exit obesity. And here we've got maybe some of these past generation anti-obesity medications combined with lifestyle intervention that might be sufficient. But that leaves 50% of the population with obesity that need to lose 10% or more body weight. And it's very difficult to do that without a medical intervention.
Go ahead.
Hello, I'm Sandra Lee. I'm the chair of Obesity Matters, and I want to thank you for this incredible work and the report that you and Lily put together, so thank you. I think it's an exciting time in the world of obesity. It's the first time in my lifetime that there's actually 3 pillars of treatment, and one of those is pharmacotherapy. And so when a patient has a prescription and they go to the pharmacy and it's not covered, it is a blow, because it bumps up against this idea, well, then maybe I don't have a chronic disease because my insurance company is not going to provide me with the medicine that I do need. And so my question is, how do I use this report and this data and a laser focus to advocate for insurance companies to cover the medicine that we need?
That truly is the entire essence of this report, and what we want you to do is take all of these findings, or we can come and get the shorter version of the infographics as well, and help people really see the impact, that long tail that we're creating. By not spending that dollar here, we're creating billions over here. And I'm also, part of me, my heart breaks when we talk about money and the value of a human life. So I always want to be cognizant of that, but it truly is. Like, you are worthy of care, you need to be able to show up, and we need more benchmarks and more support for research so that we can have this evidence that is just, you can't debate it anymore, everybody. This is real and this is happening. And one of the best things we can do is get this report into the hands of as many people as possible. We did that with our clinical practice guidelines. We continue to do that. We know we need to talk to the policymakers up here, but quite frankly, I want to get this information into the hands of every person living with obesity that's in that moment in that pharmacy. I myself am also one of those people, because we deserve a lot better. And then when you layer in his statistics as a lady who's making less money as well, like, that's the compound that we're creating is just untenable and unfair. If I have to choose between paying my rent or taking medicine for my chronic condition, that is what we're talking about. And it isn't that I'm spending my money frivolously in other places. Life is a lot right now for all of us. And now we know life is a lot for all of us, plus we've added more onto people living with obesity. So I want to empower them with this data and help take it. And we just need to start making noise. Right now, this is our preview of the report finding. You will hear from us and see from us in the following weeks, as well as we do a wider release. More concerted campaign efforts as well. And again, that's where I want to remind each and every one of you that you are now an advocate with me. I got all of your numbers. And we're going to do this together because we need to start just bombarding people and being loud and taking up the space that we deserve to take and have this conversation. We can't keep avoiding this conversation. It has to be had.
You brought up a very interesting point, which is how do I convince the payer, right? And what we see in the numbers is that 3/4 of the cost it's not borne by the payer, it's borne by society. And so we need to look at this from a societal perspective. And the burden, besides the economic burden, includes quality of life. And that is primarily borne by the person and their family and friends, right? And so when we look at either prevention or treatment and try to make the argument that the cost is going to save money, usually the direct medical savings is not going to cover the cost. So you need to look at things from a broader perspective.
And I think there's a narrative as well for employers as well, as you saw, and now having that layered on as another data point will be equally as important for those who are working with insurers to support their employees as well.
And often this can be a blind spot when you made me think of this when you're talking about employers. You know, there are fantastic employers, large employers in this country that probably have a blind spot to this fact as well. And again, we need to bring the sunlight over to that and help them understand that, okay, you want to take care of your people, here's what this looks like, and help us democratize the true definition of obesity, provide the right kind of care within our insurance coverage plans, and then dig a little deeper as well and say, okay, I don't want to just get this added to my lifestyle category. Help us have the right conversations and have it moved as a true treatment for a chronic disease. Because right now that is often a limitation, that these drugs are considered a lifestyle. It is not a lifestyle. Again, the Canadian Medical Association, the World Health Organization have recognized this as a chronic disease. We need to recognize this on every level of our society as well and give the right kind of supports to it.
Yeah, and in all the work that we do, we advocate for access to all the pillars of obesity treatment. So not just pharmacotherapy, it's all the pillars and the things that are involved in effective obesity management. But obviously the pharmacotherapy stuff is a hot topic right now, and I'm in a number of support groups online, and there was, I mentioned to you earlier, there was a conversation that was heartbreaking where someone had posted something about excitement, and I want to say this very clearly, excitement about getting a diagnosis for diabetes, because now they won't have to pay out of pocket for their medication that they've been using. How sick is that? Like, it's just terrible. So we need to kind of reframe this and approach this in a different way. And hopefully this is kind of a start of a collective push where we can start to make some really meaningful change.
And I would invite employers and all of us to also be curious and look around, because there's absolutely, this is the hottest topic right now. But then there's other components. When I think about some of the findings in the report, you know, if I knew that I'm a fantastic candidate for a job, I take a look at what the company offers. If I saw within the policies, if you're a person of size when you travel, we got you. somehow messaged in my employee handbook, I would be thrilled. I would love to work for that organization. Anything that we can do in any of those touch points, how can we change the environments that people are working in, make people feel welcome as they are, and make sure that we're thinking about those kinds of aspects, we're gonna see the right kind of amazing talent come forward. Because again, if we remove this burden, I am convinced this amount of goodwill and fantastic energy that can come back to us as a working population and how we can impact the economy could also be really fantastic. And that's where, again, Obesity Canada, we want to help. We're going to build more toolkits. We want to do more resources so we can help be a bridge and really help people make this change. And it is a change. We also need to have space and grace with each other and help people understand that they're learning something new. They might have to implement some new policies. Sorry about the paperwork, but let's figure this out because it really does, again, make it make sense.
Sir.
Virtual question here from Laura O'Driscoll with Diabetes Canada, and she wants to know how other organizations can support Obesity Canada in getting these results out.
I love this question so much. No, never. I love that question, and that is exactly what we need. Obesity Canada, it is going to be our 20th anniversary next year, but so few people, I know, but so few people truly know that we exist, and we really want to start showing up center stage. And I think, again, when we talk about this collective and the sum of us being better than the one of us, I think that is what we're going to really be pushing for. You're going to see, again, campaigns from us. Once this report comes out of embargo, we really are going to push to have those kinds of campaigns, because I think if we can start stumping on the hill together, if we can start showing up together and help draft off of what each other is working on and see that as a good thing, that would be the most fantastic place to start. But if nothing else, email lisa@obesitycanada.ca and let's start a conversation about what that can look like, because I'm sure there are ways that we can amplify work that other organizations are doing in this allied space, and there's work that you could do to help amplify us. I'm very much an all boats rise lady, so let's figure some things out together.
In the short term, when this gets published and we have all the stuff on the website, there's going to be media push and those sorts of things. I encourage anyone to share that and kind of extend the reach of our network. So, with everyone in this room and everyone virtually, we have a really large network. We can really start making some noise. So definitely share this stuff and join in on the conversation. Is there any other questions?
I'm very passionate, so you can tell me to stop at any time. But during the presentation, you mentioned that there's less participation of people living with obesity, and you weren't quite sure why. And so I speculate that that's discrimination, that people living in larger bodies don't always get the job, and they're not always represented. So if I think of my own history, I worked for a very large consulting firm on Bay Street, and when I started that job, I was what was be considered a normal weight. And then I proceeded to gain 100 pounds. I was there for 15 years. So you can imagine not only my difficulty with that, but my employer's difficulty with that. And it was very evident to me because I was probably one of two people in an office of 200 that was living with obesity. So the stats did not apply. So, I was pushed back. I was put on a different floor. I was very much told, like, can you please leave because you don't fit the mold? And I wonder if there's some advocacy work in helping people understand that people in larger bodies make huge contributions. I was lucky enough that, I was there for the first 5 years. I gained 100 pounds. I actually had to go on sick leave. So that's an important piece for payers to understand, that if you don't want to support people, they might end up on short-term disability like I was. Went back, was able to lose a considerable amount of weight, and stayed another 10 years. So I was a valuable person. I did have impact. I had contributions to make, even though I was living with obesity. And I don't know if that message gets out, because I think that for many of us, we get stopped at the door. No thanks, we're not interested in hiring you. So I wonder if there's any work at Obesity Canada in that front, helping to really demonstrate the impact that people living in larger bodies can have in corporations.
I think, Sandra, first of all, I think sharing that story is so powerful, and being able to inspire people to come forward to seek information, help, and resources to support that. We have started doing some work in workplace related to obesity and helping employers think about workplaces that are more inclusive of individuals living in larger bodies, but also demystifying obesity as a whole. And so I think there are some organizational kind of approaches for employers to start thinking about how do we approach obesity. Lisa talked about policies, approaches, but also how do we support individuals living with obesity so that they can contribute in the most effective and to their maximum potential in those spaces. And so, I think it's one of these multi-pronged approaches where we need to engage leadership of organizations and workplaces to really think about this, have the language and the knowledge and awareness of obesity as a chronic disease and the interventions, and including environments as well, physical environments, and then also empowering the people working in those workplaces to be able to be advocates, to understand that they're not alone and that there are ways in which we can make our voices louder, so to speak, in this space.
You go first.
Okay. Just 2 points. One is when we look at obesity prevalence, it tends to be higher among older and more experienced workers. And these are going to be your workers with that experience, right? So that's one point. Another thing, too, is when we look at some data from the US on, similar to the Canadian Community Health Survey, but we had some longitudinal data. First of all, if you look at populations that typically have disparities in having jobs, so by race, ethnicity, for example, the size of the disparity is correlated with economic conditions. And so if the unemployment rate is really low, you tend to see less disparity because employers are less selective, okay? When we started doing some work in the US on the relationship between obesity and labor force participation, we came up with a number. And then some new data came out, we looked at that number, and it had shrunk. In other words, obesity's negative effect on labor force participation was now smaller. And so we looked at some longer term data, and what we did find was a correlation that when the unemployment rate is high, obesity has a larger effect, and when it's low, it has a smaller effect, which is consistent with discrimination.
Very.
Yeah. But what we don't know, because the data doesn't say, is is this person not working because of their health, or is it because they couldn't get a job because of discrimination? The data just doesn't tell us. Yeah.
Oh, that makes me mad.
Yeah. Well, it's just not collected.
Well, because why?
Nobody
why
wants to
would
know.
Why would we bother? You break my brain in a different way with that. But where I was going to go in my comment as well is, absolutely, I think there is advocacy work that we should all be doing together as well. That really is about our media, and that toothpaste is out of the tube. We know that. We're not going to be able to clean up social media or media full stop, but I think there is a lot that we could do about helping us be seen differently. You know, I was just at an International Weight Bias Summit, and I was like, I could probably tell you every very special episode where there was a fat girl, because I felt, oh my God, there's somebody that looks like me, that's a teenager that's like me, and they're on a show finally. What if we just had diverse body types showing up everywhere all the time, and it wasn't this tokenism where it's like, oh, we're going to learn about her this week, and then she's never going to be seen again? That's also not fair. That's also what's perpetuating this. So I think the more that we can press the media to start doing better representation, be that through, genuinely produced television shows. But quite honestly, I said it earlier as well, I just was in Montreal, and there's fantastic news pickup about some great work that's happening in Quebec, but the B-roll that runs behind it is just these slovenly, headless humans. And I know we've all seen it on the news, and I hope that when this report comes out and we do press around it, part of me hopes you see those images, because part of me is going to be able to show up and be very angry about it, because it's not fair. We are not headless people. We are not always got a burger in this hand and a burger in this hand. Sometimes we're just moms and dads who are doing all the things that all of us do. And so we're grossly misrepresented even when they're talking about us. And that's, I think, a moment of advocacy for us. And that's also, again, an opportunity for all my new advocates in the room. If you see that on the news, it doesn't take much to just drop a note and let somebody know. You might not be aware, but that was really stigmatizing and actually counterbalanced all of the good reporting that you were doing.
And by the way, here's a link to
Proper imagery.
where
and-
this stuff exists.
Yes.
And Sandra, to your point about advocacy, I think one of the things that's some of the most powerful advocacy is storytelling. And, you know, you and I and Lisa and Pretty, like, we've been pretty comfortable doing this, and we can go and talk. But there is a whole lot of people out there that are not comfortable talking about their experience, or it's something that they don't talk about and they hide, or they keep quiet to themselves. And I think we need to start pushing that a little bit and kind of getting more people to share so that more people can see themselves in you and your story. You've got a very powerful story there with that workplace situation, and there is lots of people that are like you that have had that experience or something like that. And if they hear you speaking and telling that story, they're going to go, I had that too. And then they can join the push, and they can, you know, people need to know they're not alone. And so that's definitely something we can work on.
Community is a huge part of solving this problem for people living with obesity. At Obesity Canada, we have OC Connect, which is our online community. Obesity Matters offers great resources for patient communities as well. And the more people that we can get to start showing up for themselves and for this greater collective, I think the better the off we're all going to be, for sure.
Is there any more? Or we're good? I think we are good. So with that, I'd like to thank you all for being part of this very important discussion on the cost of inaction and treating obesity in Canada. The findings of this report are very insightful, and they definitely emphasize the need for some urgent action. So thank you very much for being part of this. I'd like to thank our speakers for being here and providing their input and insights into this. Today we gave you a bit of an overlook, an advanced look of the cost of inaction report that's going to be coming out. We do have lots of plans for when this does get published and to push it out more widely. And we ask that you join us in doing that. We already mentioned that a little bit. In early November, the top line findings are going to be made public, highlighting the insights and overarching trends. This will be available and accessible on our website. The full report is expected to be published before the end of the year. And additionally, we plan to conduct media outreach and continue to raise awareness about this important discussion. And we're also going to have a dedicated advocacy campaign that goes along with it. So please keep an eye out for that. When you see it, share it, join the conversation, comment, put it into your networks, and be a part of this with us. As we leave here today, I hope we can commit to keeping the conversation going, whether it's advocating for policy change, supporting your own community, or simply raising awareness about weight bias and stigma. That can be a big help to this movement. Let's continue to work together to get patients what they need and ensure that the system and the community are there to support them. Thank you all again for joining us, and we hope you leave here informed and ready to take action.
Thank you.
Good job.